Thank you, Damaris. And I learned this morning that Damaris's mom and my dad are from the same village. So, wow. Small world. Good morning, everyone. I expect a bit more energy in this room. Good morning. Great. After yesterday's partying, yes, keep the energy going. Huh? So Brian Nzano is my name, and I just thank everyone for turning up for this workshop and the organizers for according me this time. I work with Chai, and I know there are a few Chai people in the room as well. I am going to speak to a couple of things. And yesterday's debate for me was an incredible foundation. I had the so-called winning team say, show me the menu. And I had the less winning team, I guess, say, show me the money. And if you've watched or heard of a movie, Jerry Maguire, show me the money was quite a statement. But I hope I'll convince us that as youth, as adolescents, we are going to play an incredible role in quickening the introduction of long-acting products for HIV prevention and treatment. I have no conflicts of interest to declare. So I'll just run us through a quick reminder of that landscape and background that is HIV, that speaks to you and I, and then take a deeper dive into the crux of our discussion today, that is long-acting injectables, and then a few recommendations from what we see today. Again, Dr. Nyaratso and a couple of speakers yesterday reminded us of how, the burden and struggle is still in front of us. That yes, from about 2010, when we had about 2.2 million new infections per year, we've seen a reduction to 1.5 million per year in 2020, but still way short of that UNAIDS target of cutting transmission to about 500K per year. And if you think about the revised target of 370K in 2025, next year, in all likelihood, we will not reach that target, which should be a bit baffling and sobering for you and I. Importantly, if you call Sub-Saharan Africa home, like I believe most of us do, or you love Sub-Saharan Africa, I think, again, this slide speaks to how, one, the burden is significant in the region, but two, speaks to adolescent girls and young women, and by proxy, youth in general, that we have a disproportionate burden of new HIV infections in this special population. So to your left, you have varying shades of red from sub 1% in West and Central Africa to the darker shades of red in Southern Africa. So literally the farther south you travel, the relatively higher the HIV incidence or rate of new HIV infections. And that should be a bit sobering given we are in 2024. And then to your right, just a quick reminder yet again that not only are 75% of those new infections among adolescents and young people across the region, but they were in adolescent girls and young women, and again, should be sobering. And then even more sobering is 25% of all those new infections are amongst this special population of adolescent girls and young women, but that's only 10% of the population of the continent. And again, hopefully that sheds more light to the burden that is before us. I could go on and on, but we appreciate even further that we not only see significant proportion of new infections in those populations, but the vulnerability and alignment or engagement to care is lower in these young people and key populations for whom there is significant overlap. So to your left, yet again, 6 of 7 new infections were in girls 15 to 19. 54% of that 1.7 million adolescents on antiretroviral therapy in 2020 were on ART versus a 73% of all PLHIVs. Again, the discrepancies are rather in our faces. And then for key populations, very clear that they shouldered 65% of all new infections in 2020. And though we have limited data available, we know that ART coverage is significantly lower in those special populations, including young people versus the general population. So how do we close that gap? And I think that's the gist of our matter today. And I think we've come to appreciate that we need innovations. And I think I had someone, I think it was Trevor, mention that, oh yes, we're a young population, we are innovative. Yes, the innovations have to be driven both by manufacturer, but from end users and the recipients of care that we are. And beyond those new products, beyond those novel service delivery options, I think to your right is the all-important matter that at the center of all these innovations and approaches should be the recipient of care, should be you, should be me, should be community, should be the youth. And there is luckily incremental appreciation of the value and the benefit of all things person and community-centered services, because the client should determine how, where, how, and what services they get. So to these products, and Amy did an incredible job in speaking to lenacapavir, but I want to say as well that there's a diverse pipeline of promising HIV treatment and prevention products. To your right, you have those widely approved, and we know treatment as prevention has been part and parcel of our treatment approach for years, to the relatively novel and early introduction products like cabotegravir. And I know in this room there are people from Zimbabwe, from Zambia, from Uganda, who will tell you there's early introduction work going on for prevention more than treatment, of course. And then to your farther left, you have early development products. So BNABs, broadly neutralizing antibodies, are, I think, at the forefront of that conversation. Think of BNABs as that C10 if you're from Zimbabwe, or GSU if you're in Kenya, or Special Forces Command if you're from Uganda, that you have this agent that will gladly block the virus from reaching its target before things explode. But we know that in lenacapavir and cabotegravir in particular, we've seen rather quickening of movement around these products, and I'll speak a bit more to them. And implants were brought up earlier, that yes, granted we have that range of products, but there should be more investment and more innovation around some more novel drug delivery mechanisms. So implants, we have a lot of learning from sexual and reproductive health. I spoke of BNABs earlier, and microarray patches. And believe it or not, there is ongoing work across these formulations, if you will, that we should be moving towards a range of options that are available for the youth and those who are in chronic care or need them for prevention, for that matter. And in front of you really is to quickly say that there is indeed quite a menu of antiretroviral drugs being investigated, both a spectrum of prevention and treatment. And again, cabotegravir, lenacapavir, islatravir, and TAF, or talafenamide, are the forefront of those conversations for pre-exposure prophylaxis and or treatment. And I won't dwell much on this. Then there's a matter of recognizing that, yes, individually, some of these molecules have shown great benefit. And how do we explore where we can co-administer or co-use them? And I specifically bring out islatravir and lenacapavir because they are at the forefront of that excitement of long-acting options for treatment and prevention, and indeed will give us option for a paradigm shift in our approach to antiretroviral treatment, certainly for the youth. And in lenacapavir, as Amy mentioned, we have a new in-class capsid inhibitor. In islatravir, we have a relatively new class of ARVs as well called transcriptase translocation inhibitors as well. So we have relatively novel options within reach. And then to your right, to again identify that there are all these ongoing studies or completed studies that are providing us evidence of use across geographies, and geographies that speak to you and I, as we heard from Purpose One, which is always important. And when we think through that range of products, what I'm hoping for is that you and I appreciate that we are drawing closer to that day when we can walk as you do into KFC and look at a range of options and say, you know what, I'm going vegan for the next 1 year. Or I will not, I'm vegetarian for life. And that you can work through options that work for you in terms of formulation, in terms of efficacy, in terms of convenience of dosing, in terms of those adverse events that you can bear or not bear. And lenacapavir, to extreme right, I think has increased that conversation even better. Okay, if we have a product that is easily 100% efficacious in prevention, then that theoretically should be on top of your pyramid. Then that vaginal ring for prevention, I'm not sure about that 50% efficacy. And the idea that I have to wear it daily and use it daily for 28 days, if I am in my menses, I still have to think through application and what have you. Long and short, we need to start thinking about menus that are applicable by individual. And I think for prevention, we're seeing a lot more movement than treatment. So to how do we move on and get these products in country, in our programs for use by those who need them? So one is to recognize that we have to support product choice. Show me the menu, show me the menu, show me the menu. I can't say it enough. And I think we need to recognize as well there is no one size fits all. People have preferences. What works for me does not work for the other. We need to start thinking through, and programs are thinking through this. How do we create menus that allow me to switch products? Like I said, I can be vegan, I can be vegetarian, I can be pescatarian, but have products that work for me short to long term. But recognizing that there should be delivery models that allow for me to use them based off the intricacies of each and every product. But if I need to go to a facility and get an injection, I hope I'll have the privacy for that injection. I'll have the right education around adverse events and what have you. Then there is recognizing that there should be some infrastructure for laboratory monitoring and what have you, depending on where I get this product from. Now, you might adopt the product. Importantly, there has to be a five-fold look at what works for patient, what works for program. And what you have in front of you is really that range of questions that about every program thinks through, from clinical benefit to convenience on the recipient of use arm. Then from the program, they say, show me the money. So you had Professor Mulenga yesterday speak of cost quite significantly, and that is huge. Then we have to think through availability. Professor Mulenga yet again brought up supply. Do you have the supply for what I need? And then there are the complexities of introducing these products across programs. Taking a long-acting drug to Lodwar in Kenya might not be the simple approach as it is in Greater Nairobi in Kenya. Importantly, that product adoption is one. Product availability is the other. Product uptake is a facet, is a mix of multiple pieces in this maze. That there should be plans around monitoring facility uptake, supply yet again. That product should be registered. Do we think that if registered in Kenya means registered in Uganda and what have you? And then the stakeholder buy-in, that the youth have to be at the forefront or at the table to make that conversation viable. And at CHI, we have learned that if you want to prepare a geography for product adoption, activities need to start 2 years ahead of market entry. So if you're in this room and you've had Purpose One come through, now is the time, to start making that noise and amplifying what we understand through that decision-making matrix for programs or for recipients of care, around budgeting. I hope we have people here that sit in those CCMs and what have you, procurement and all things forecasting, and then short to long-term monitoring in country. And I can speak to this slide over and over again, but long and short is you really need about a 2-year window to work through to ensure that you have quality and adequate product entry across your geographies. In conclusion, I hope I have made it clear that, we have these long-acting and novel products available. They will no doubt facilitate optimal HIV prevention and treatment for adolescents, for youth, and they are critically needed. Importantly, they are here. The evidence is very clear for lenacapavir, for cabotegravir, for islatravir. Evidence of efficacy, evidence of benefit in youth and adolescents, which is no doubt evolving, evidence of feasibility of their use in low to medium income countries. And Purpose One gives us a great example, a study, as we heard from Amy, focused on adolescent girls and women, conducted in South Africa and Uganda. Do you need better examples of countries to show you how it can be done? And then lastly, for their smooth introduction, and I repeat this, for their smooth introduction and uptake, it has to be client-centered, youth-friendly. we have to start thinking about menus. Show me the menu, okay? That are designed by youth who understand these products better. And then the health system has to be prepared to absorb them and to receive them, facilitated by the youth. Customer is king, and this applies across every area. And I think adolescents and youth must be front and center in shaping our country's plans to facilitate the entry of these long-acting products. So thank you, asanteni sana.